Greetings, class. Welcome to your online lecture regarding Hinkle Chapter 46. We're going to cover the oral disorders today and start discussing most of the esophageal disorders that are within this chapter. We will finish esophageal disorders when we are face-to-face next time. So oral health includes teeth, lips, mouth, and gums. The teeth and the gums disorders you should be familiar with already. The periaptical abscess is just an abscess tooth. When you look at the lips, your common cold sore is a herpes simplex 1. Actinic cheilitis is actually drying and chapping of the corners of the lip mouth, or usually corners of the lips in the mouth area there. A chancre is the first sign and symptom of syphilis. We can see this in the peri area, but also can see these occur in the oral area as well. For the mouth, leukoplakia is white patchy areas, usually on the outer aspects of the tongue. They can have protrusions out of them that can make them look hairy. And then aphthous ulcers are just another name for canker sores. And stomatitis we're going to spend a little bit more time on in a few minutes here. Just so you know, all of these things are well defined for you in Table 46-1 in your Hinkle textbook. In order to promote good oral health, we need to make sure that our patients are practicing good flossing and brushing of their teeth, as well as regular dental care. We want to encourage the reduction of starches and sugars. This helps decrease the incidence of cavities. Also maintaining good nutrition, and by that not also having a well-balanced diet, but making sure they get their full regimen of B vitamins, folate, and zinc supplements. When we think about fluorinated water, we need to ask our patients if they drink well water, bottled water, or if they drink city water. Most city water sources within the United States have been fluorinated, but people who drink only bottled water or well water will need some regular applications of fluoride to their teeth. I'm always preaching refraining from smoking, and reduced or no alcohol consumption is going to help with good oral health, and controlling diabetes, of course, will be important as well. It's interesting because there has been research that has shown some correlation between periodontal disease and heart disease, which is secondary to an inflammatory response, and also other correlations between oral health and chronic disease such as diabetes, heart disease, stroke, premature, and low birth weight as well. Stomatitis, as I mentioned earlier, is just another word for mouth sores, and these are painful ulcerations within the oral cavity. They can be classified in two different ways, primary or secondary. Secondary is the easiest to define. Secondary is just an opportunist infection that occurs because someone is immunocompromised. So think of your HIV patients who have been on antibiotics and therefore their normal flora has been reduced. They have a fungal infection or a superbacterial infection. And of course, chemotherapy can also cause oral sores, and we'll learn more about this when we talk about chemotherapy in our next unit on cancer, or in a couple units from now. Primary there can be non-infectious or infectious ones. Non-infectious would be your aphthous, or could be infectious like a herpes simplex type 1. Or it can be from trauma or from our nutritional deficiencies, specifically the nutritional items we mentioned earlier. So when you think about providing oral hygiene, especially for our patients who can't care for their mouth and their teeth themselves, so you think about your comatose patients, your ICU patients, your patients who have endured a stroke, things that we would do for them would include stimulating their gums and cleaning their mouth every 2 hours with a soft toothbrush or one of those foam swabs, or with just gauze, getting in there and moving the saliva around, rubbing off the plaque, just stimulating those gums in order to promote better circulation. We need to remember that our patients who aren't eating don't produce as much saliva either, and it could be because they're ill as well, so we want to use an artificial saliva product if that's possible, or just rinsing with normal saline or a sodium bicarb solution. We want to avoid mouthwash that contains alcohol or lemon glycerin swabs because these are drying to those mucous membranes. And if they are eating, we want to make sure that their foods are soft, bland and non-acidic. Maybe you've had a canker sore in your mouth and eaten something like hot sauce or salsa, and that can really irritate that sore and make it worse. And of course, for healing to occur, we want to make sure they have an adequate source of protein and of vitamin C. We can provide some topical analgesics for them. Viscous lidocaine is one of those things. Camphorphenol or benzocaine. Benzocaine is an ambisol or oral base, which is medication that they use for children when they're teething, same kind of idea. So we can put these on their canker sores or their stomatitis if they have them in their mouth. Antimicrobials, if this is a result of a supertype infection or an opportunistic infection, we may use a tetracycline syrup. So just like we would have them do a nystatin, swish and spit, or swish and swallow, we may have them do a swish and swallow for recurrent aphthis, missing an H there, sorry about that, ulcers in their mouth. Acyclovir can be used for herpes simplex, nystatin we already mentioned, and then there are steroids we can use for different types of medications if it's an anti-inflammatory type process that's occurring. And then there are immune modulators that come in topical forms. I don't necessarily need you to know those for the test, but I just want you to be aware that those are out there. Each facility may have a special combination of medications that usually contain things like lidocaine and diphenhydramine and an antacid like Maalox or Mylanta or something like that. Sometimes they even have nystatin in them or a liquid corticosteroid. Whatever the combination is, they'll call this their magic mouthwash, and this will be used for patients who have a lot of stomatitis or problems with their mouth. So that may be mixed for the patient and sent with them for comfort for them. When we think about the lymphatic drainage system of the head and neck, we need to I just wanted to put this picture in here for you to remind you of the numerous numbers of lymph nodes that are located throughout the head and neck area, so that when we start talking about infection here, we can feel these lymph nodes to see if they have gotten larger or it's swollen because of an infection in the mouth or in the neck area. And this will come into play as we discuss our next few topics here. Our saliva glands do specific things for us. Not only do they help lubricate whatever we put in our mouth in order to help passage from our mouth through our esophagus into our stomach, saliva also gives some protection against harmful bacteria, and it also begins the digestion process. There are enzymes that are contained in your saliva which start that digestive process. So disorders of the salivary glands can include those that are listed for you there. Some of them are caused by viral infections like parotitis or by bacterial infections. Viral infections for parotitis can be from mumps or can be from Staph aureus. Dentitis can be a primary problem or a secondary problem. If it's secondary, it usually occurs because of radiation that has been done to the neck. Liathus means that there is stones that develop within the salivary glands, and those maybe need to be broken up by lithotripsy, which is sound waves that break that up. And if they happen to develop cancer, we can have them removed, or that cancer removed because of surgery, radiation, chemo. Those can be used to treat those malignancies. When we think about cancer of the oral cavity, it's important to remember that if it is detected prior to the spread of lymph nodes, there is a 5-year 80% survival rate. But because of the high amount of lymph nodes that are in this area, it needs to be caught quite early. Risk factors for cancer of the oral cavity include age. Just the aging process can put you more apt at developing irregular cells in your oral mucosa area, and then the use of alcohol and tobacco. Specifically, smoking tobacco can be bad, but chewing tobacco, there's a high correlation between chewing tobacco and oral cancer. Most of the time, this is squamous cell cancer, and it can be basal cell, which starts with the lips. Kaposi sarcoma usually is a nodule on the hard palate, and this begins mostly with our patients who are infected with HIV/AIDS. In order to prevent oral cancer, we want to reduce our risk factors, which are listed above, and make sure that people have their dental exams every 6 to 12 months, and this includes a thorough inspection and palpation of that mouth area. So what do manifestations of oral cancer look like? If someone has a painful bump or sore that does not heal, and usually we say if it doesn't heal within 2 weeks, that is suspicious for some sort of abnormal cell growth. Therefore, it should be examined and biopsied. Later manifestations include more tenderness than usual associated with a canker sore, difficulty in chewing or swallowing, speaking. It can cough up blood and blunted sputum, and then that enlargement of those cervical lymph nodes because of the excess metabolic activity that's occurring with those cancer cells. Nursing diagnoses that we focus on for our patients with oral cancers include that if you start with your airway, risk for ineffective airway clearance because there is the possibility of blocking off that airway because of the decreased saliva production and mucus production. It could prevent the clearance of the airway as well. Impaired oral mucosal membranes, impaired verbal communication, disturbed body image, acute pain, risk for infection, impaired swallowing, imbalanced nutrition, potential for metastases. All of those are your common nursing diagnosis that would apply to your patients who have an oral cancer. Medically, we intervene for those patients by excising or removing what the cancer that is there. We could do some cryotherapy, which is freezing of those cells and removing them. Some laser therapy, which uses lasers in order to remove the cancer cells and the surrounding tissue. We may treat them with radiation, localized radiation to kill those cells and any potentially other cells that would be that we can't see that they've started to change in structure. Chemotherapy, and this is specifically used if we have had a suspicion that has been spread to other parts of the body. And pharmacogenics is one type of chemotherapy, or it could be a combination. We call this multimodal, which means we're going to use more than one of these, and it all depends upon what staging of the oral cancer has occurred. So when we think about specific nursing interventions for our patients with oral cancer, we're going to really evaluate that airway, making sure we keep the head of the bed up, doing really good mouth care. Xerostomia, which is another word for dry mouth, occurs frequently with these patients, so we want to offer saliva substitutes. They can also have problems with stomatitis, so we'll want to be aware of what methods and what medications, what comfort methods, interventions we can have on hand to help them with that. Adequate fluids in nutrition, remember those vitamin B, enough vitamin C, folate, and protein in order to help maintain healing, promote healing, and then we want to make sure that they are not losing too much weight, which happens frequently with our cancer patients, especially with our oral cancer patients, because eating can be very painful. We want to minimize discomfort and pain, promote communication, and then of course promote and prevent infection. Good patient outcomes, we're going to keep most of those intact mucous membranes as much as possible, except for whichever part we may have incised because of the removal of those faulty or cancerous cells. Make sure they maintain a desirable body weight, promote a good positive self-image for these patients, keep them comfortable, decrease their fears regarding their prognosis, their pain, isolation, their ability to cope with their diagnosis, preventing infection, and then of course keeping them informed about the progression of their disease. There are times we need to do a radical neck dissection, so it's neck dissection or a selective radical neck dissection of these areas in order to remove possible lymph node involvement for these cancers. A here is a radical neck where the sternocleidomastoid muscle is removed. B is selective or modified radical neck dissection, and this is where the muscle remains intact. And C means after closure, they've had a trach or other drainage tubes have been kept into place. So the trach would be coming out the front there, and the drainage tubes would be out of the side. So that explains the ABCD there. When we think about nursing process for our patients with a radical neck dissection, we always start with assessment. We want to know before surgery how much do they know about their diagnosis, and then to also assess whether there are risks for potential complications. What will they need to know after surgery? What will they need to know about taking care of their airway, about breathing, about communication, about potential swelling and wound systems, all those things. After surgery, we'll want to make sure as nurses that we really thoroughly assess that airway. We're going to auscultate not only their lungs, but auscultate over that trachea for stridor. Maybe that's that high, remember that's that high-pitched sound that will indicate obstruction, and that occurs because of swelling in the area. Making sure they stay comfortable, keeping their pain under control. And there's a lot of vascularization in that neck area, so monitoring for potential bleeding and making sure that the wound drainage systems are intact and draining effectively. Nursing diagnoses that apply here are listed here for you to see. Collaboratively, we'll be working together with other disciplines to make sure that the hemorrhage factor doesn't play in here. There's a chi fistula, which is the disruption of the thoracic duct or the right lymphatic duct, so the lymph flows out into the thoracic cavity. There can be nerve injury, and so we want to make sure that we want to monitor for that to make sure that they have no nerve injury specifically to swallowing. And then maintain that airway, it's a huge deal. Listening for that stridor, keeping them in Fowler's position, which is that high position to promote drainage. We don't want them to be flat. We want them to be in high Fowler's position. Encourage coughing and deep breathing. Most of these patients will have a trach in place because of the amount of swelling that occurs during this surgery. So making sure we do good trach care as required or as indicated. Other things to do as nurses is we need to be really, really careful when we suction those trachs in order to protect those suture lines. We'll want to support that head and neck when moving the patient because, again, they've had a lot of extensive cutting and revamping of that neck area in order to remove any potentially infected lymph nodes or muscle that may be there. So when we teach our patients about their surgery, we want to make sure that they understand the extent of their surgery, what happened, and then what to expect post-operatively, and then to remind them post-operatively of what we taught them pre-operatively. Include the family in this education as well, so that they are equipped to do good self-care at home and to manage their care at home. They need to know what signs and symptoms they need to report, for example, shortness of breath, signs and symptoms of infection, that sort of thing. Making sure they know how to take care of their trach site and their wounds and their dressings and drains, what kind of diet they need to be on, what medications they'll be needed, and then the exercises and activities they will need to do in order to rehab those neck muscles. And there is a good diagram in your book on the rehab exercises for these radical neck dissection patients. Other support systems that will be in place will be speech therapy, making sure they have support resources and follow-up care in place as well. We've talked quite a bit about nutrition already. I just want to reiterate that it's really important that we assess the nutritional state prior to surgery and try to intervene early in order to prevent any potentially complicating nutritional problems. We want to encourage high density, high quality intake. So avoidance of empty calories, those are your fun sugary snacks. And we want high density to mean high protein. It can be high calorie, but high quality calorie for that. And then also the diet will need to be not modified into a liquid diet or a soft parade diet with liquid foods at home. Sometimes it is harder to get a high quality, high density intake with soft parade or liquid foods. So think Ensure, a Boost, something like that. Patients should understand that they might be on these supplements for a while in order to provide them with the calories and protein and nutritional elements that they require. As always, we need to consider what our patient preferences and if they have any cultural considerations, and then always providing good oral care before and after eating, and then have the patients understand that they may have a nasogastric tube or a gastrostomy tube after surgery in order to make sure they get the nutrition they need before their esophagus is ready to pass food because of the swelling that can occur post-operatively with this surgery. So moving on to the esophagus, disorders of the esophagus, there can be diverticula. In any of the GI system we can have diverticula, and this is just an outpouching of the mucosa or the submucosa, and this it protrudes through a weak portion of the musculature, and in this case it'd be of the esophagus. And there are different types depending on that location of that outpouching. Clinical manifestations of this can be dysphagia, which is just difficulty swallowing. This is the most common, or if they swallow, they feel like they can't, that something gets stuck or gets caught. But they can also experience burping, regurgitation, and gurgling noises after they eat. Sometimes they have a sense of fullness in the upper esophagus area. You can also have some halitosis or a sour taste in the mouth because of the food and objects that get caught and liquid that get caught in this pouch off the esophagus. To diagnose the diverticula, we want to make sure the patient gets referred to a gastroenterologist who can do an EEG or a barium swallow study. Management of this is usually dietary and lifestyle. If it becomes too problematic, we may have them have surgery. Perforation of the esophagus is usually from injury. Most commonly, this is from stab wounds or bullet wounds or motor vehicle accident, or it could be because of an error during surgery. Perforation of the esophagus is very, very painful. It needs antibiotics quickly and broad spectrum antibiotics because of the high risk for infection due to the normal flora that dwell in your mouth and your upper esophagus region. They will need to be NPO, of course, until the surgery repairs this perforation of the esophagus. Foreign bodies are things that don't pass through the esophagus but get stuck there. Examples that we worry about are things that contain like button batteries or mercury that need to be removed because we don't want them to pass through the whole esophageal system, because this can result to chemical burns or chemical perforations. But most other foreign objects, if they're not too large, will pass on their own. Chemical burns, these are usually from swallowing something that has either a strong strong base or a strong acid. Whether this is intentionally or unintentionally. This would also happen because of an undissolved medication. So if a pill that's supposed to be dissolved in your stomach gets stuck in your esophagus and starts to dissolve, because again you have normal enzymes, digestive enzymes in your saliva, it starts to break down that medication. That medication can burn, cause a chemical burn in the esophagus. Button batteries are another thing that children tend to swallow. Those are those small batteries that get put in things like watches or hearing aids, for example. Lips and mouth and your pharynx can be burned. This can also, when these burns occur, we can have some edema that occurs as well. And these symptoms can be very serious and can include shock. So remember that the burning can occur on the way down. So we either want it to be neutralized rather than lavaged out. And if you don't want to induce vomiting because you don't want to cause burning on the way out. So we may put in an NG tube and then give some activated charcoal in order to neutralize that chemical, and then remove it through the NG tube and suctioning so that we don't cause burning on the way down and on the way back out. And scarring can occur whenever this burn takes place, and whenever we have scarring, we can have healing that causes strictures, so therefore your normal peristaltic movement of your esophagus doesn't occur and a stricture happens, and then we can have some need for some dilation or surgery in order to manage those strictures. That's it for this first part of oral disorders for our online lecture. I'll see you in class on Friday, and we'll start GI day number 2.